Hello all. Today I'm going to talk about some of the CPHQ topics. So I'm going to cover the topics like domains of quality, key dimensions of quality, quality management principles, quality management philosophy, adverse points on managing quality, service and products, structure, process, outcome, common weaknesses in monitoring and evaluation, waste in healthcare, rules of healthcare reform, ISO 9000, cause and effect diagram, how to write quality improvement project charter, Duran's model for QI, leadership styles, run chart rules, concept of customer time management, never events, and some of the review questions. So the domains of quality, there are 6 domains in quality. They are also called the aims of quality or framework for quality. The acronym used is STEEP, STEEP. So safe, that is avoid injuries or do no harm to the patients. Timely, reduce wait and harmful delays. Effective, providing service based on scientific knowledge. Avoid underuse, that is lack of preventive care like vaccines, under management of chronic diseases, etc. So avoid underuse, that means you should do the preventive care on a timely manner. And overuse like unnecessary lab works, x-rays, medical imaging, etc. Then continuing efficient. Efficient means avoiding waste. Waste of equipment, waste of supplies, ideas, energy, and maximizing high quality patient outcome. Equitable. Providing care that does not vary in quality because of personal characteristics like gender, ethnicity, geographical location, or socioeconomic status. So it should be provided to everyone, all the populations. Then patient-centered, providing care that is respectful and responsive to individual preferences, needs and values, ensuring patient values guides all clinical decisions. So it should be patient-centered. So let's talk about key dimensions of quality. The dimensions of quality are appropriateness, availability, competency, continuity, effectiveness, efficiency, efficacy, prevention or early detection, respect and caring, safety, and timeliness. Let's talk about one by one. Appropriateness means the degree to which the care and the services provided are relevant to an individual clinical needs, suitable resources utilization. That's called appropriateness. So the degree to which the care and services are provided to the relevant to an individual. Availability, the degree to which appropriate care and services are accessible and obtainable to meet the individual needs. So that is called availability. Competency means practitioners' ability to produce both health and satisfaction of customers. So degree to which practitioner adheres to the standards, the clinical standards, that is called competency. So this is practitioner centered mainly. Then continuity, that is coordination of needed healthcare services. So coordination between the services like rehabilitation services, nutritional services, medical services, pharmaceutical care services, or different healthcare services, that is called continuity. Then effectiveness, degree to which care is provided in the correct manner using the current scientific knowledge. Example, adopting new clinical protocols in pain management based on new research. So effectiveness is mainly related to scientific knowledge, current scientific knowledge. Efficiency is the relationship between the outcome and the resources used to deliver care, that is input-output relationship. So the maximum output with least input. Example, streamline the workflow to maximize productivity, automating repetitive tasks and remove bottlenecks, etc. Efficacy means the potential or the capacity or capability to produce the desired outcome. For example, the vaccine's efficacy to prevent a disease, metformin's efficacy to treat the diabetes mellitus. So this is called efficacy. So these terms you need to you need to understand: effectiveness, efficiency, and efficacy. What is the difference between all these things? Then prevention or early detection, identification of risk factors, promotion of health and prevention of disease. That's called prevention or early detection. Then respect and caring, sensitivity for the individual's needs, expectations, and individual differences. So identifying the patient's needs and their expectations and individualized care, that is called respect and caring. Safety is zero harm, free of hazards, because these patients come to the hospital and they believe that this is safe for them. So we should consider that all the time. Timeliness means care is provided the most beneficial or necessary time. Quality management principles. So there are few quality management principles. Let's talk about this. Productive work is accomplished through processes. So there should be a group of processes to reach the outcome. Each person in the organization is part of one or more processes. So to provide to cure the disease, so many people are part of this one: physician, nurses, physiotherapist, and then the pharmacist. A lot of people are part of one or more processes. Sound customer provider relationships are absolutely necessary for sound quality management. For the quality management, the relationship is very important. The main source of quality defects is problem in the processes. So it is not about the problem in individual needs. Human error can happen anytime. So what is our responsibility is to make the processes and the systems perfect. Old assumption is quality fails when people do the right thing wrong. But it is just people centered, but it is not in that way. It should be the system issues, right? Quality, then poor quality is costly. So quality improvement takes two forms: improvements resulting form, that is reduction in deficiencies and meet customer needs. Both are linked to cost. So poor quality, if you made anything that was done wrongly, it will cost rework, that is costly, correct? So reduction in deficiency is very important. Also meeting the customer needs is very important. Then understanding the variability of processes is key to improve quality. There are uncontrollable variables like deficiencies among individuals, diseases, issues of patient compliance, practitioner techniques, and comorbidities to be understood. So there are uncontrollable variables, like, because there will be always individual differences. One practitioner is doing the things in a way and the other one is doing in a different way. So there is a lot of variability within the healthcare system. So understanding the variability of processes is key to improve quality. So how we can fix this issue? By standardization. By providing standardization and providing a specific guidelines, we can reduce the variability. Quality control should focus on the most vital processes that influence quality of patient care. Quality management principles continued. The modern approach of quality is grounded in scientific and statistical thinking. So think about the scientific knowledge as well as the data. Data is the key in quality management. Total employee involvement is critical. So the employee should be involved totally for the success or for the quality, maintaining quality. New organizational structures can help achieve quality improvement. So the organizational structure should be streamlined. That will help in achieving quality improvement. Quality management employs three basic closely interrelated activities: quality planning, quality control, and quality improvement. I'm talking about all these three things in a different slide. So total quality management philosophy. There is some philosophy. What is that? An organization-wide management philosophy and a top-level commitment to provide value to all customers through creating an environment of continuous improvement of people's skills and processes and building excellence to every aspect of the organization. So this is the total quality management philosophy. So this is a total. So that is an organization-wide management. So this has a top level commitment. So top level commitment is from the bottom, from the top level until the frontliners. So there should be a commitment. Why we should give that one? To provide value to all customers through creating an environment of continuous improvement. So it doesn't stop. It always continually improving of people skill and processes. So it's about the skill or competency of the staff as well as the processes and building excellence in every aspect of the organization. So that is called total quality management philosophy. So total quality management philosophy, it has few key concepts. That is top management leadership. So the involvement of top management is very important. And creating corporate framework for quality. So they should have a framework how this should be done. That's what is the structure of the quality. and transformation of the corporate culture. So it needs to change the culture. The whole culture needs to be changed. And always we need to think of customer focus. So the patient focus. Patient should be at the center of the healthcare system, and the process focus. So the process also needs to be streamlined. How it can be streamlined? Some of them can be automated. The repeated tasks can be automated. So how we can streamline the process to achieve the desired outcome? That's very important. Collaborative approach for process improvement. So they should have a collaboration and communication. Communication and collaboration is very important for total quality management. Employee education and training. So the staff should be educated and trained in a regular basis or with a new equipment, launching of new equipment. So there will be standardization of the processes. Then learning by practice and teaching. So learn by practice and also teach them, teaching. Then benchmarking. Benchmarking means, I have another slide about benchmarking. Benchmarking is identifying or comparing the organization with other hospitals or other organizations having higher standards, and see what they are doing differently to achieve these standards and adopting to that practice. That is called benchmarking. So NTNQI, like National Database on Nursing Quality Indicators, it provides a platform for benchmarking. So like it has a lot of organizations, they join together in that platform, and all the indicators, nursing quality indicators like falls, pressure injuries, CLABSI, that is central line infections, bloodstream infections, then urinary tract infections, all these data is input into the individual units data is input into that platform, and then compare the results of this organization with other organization, like maybe with the same bed capacity or same teaching status, or maybe some of the hospitals are magnet hospitals. So you comparing it with another hospital with the same capacity, and then you are finding out in terms of these indicators where they are standing. Are they underperforming or are they overperforming? So if underperforming, they have to find out what is the strategies that organizations who show success in that indicator, and you can adopt into that that strategy. And that is what is called benchmarking. So one of the total quality management philosophy is benchmarking, finding out where they stand in terms of their indicators. Are they doing well or are they doing bad, and then improving from there. That is called benchmarking. Then quality measurement and statistics. So data, measuring the data is the key for the quality improvement. Recognition and reward. So the units having high keeping high standards and high values needs to be recognized and rewarded. And then management integration. So integration and collaboration is another concept of the total quality management. Then why it is important? An increased top-down and bottom-up emphasis on quality with top management, demonstrating leadership being responsive rather than directive. So there should have a from the top level leadership to the bottom down frontliners. So there should be an increased bottom-up emphasis on quality with top management. The leaders are demonstrating their leadership being responsive rather than directive, rather than telling them do this, do this, do this. They are responsible for the quality management, and then they should guide the lower level to reach the quality. So decreased emphasis on inspection and surveillance. So why total quality management philosophy is important? Because there should be an involvement of the top level as well as the bottom level members, and also it decreased the emphasis on inspection and surveillance. So quality is doing it right even if no one is looking. So high quality will be maintained all the time, so that no need for the inspection and surveillance. Focus on systems rather than individuals. So rather than who did this mistake, check into why this happened, why this mistake happened, what was the process gap, why this process gap happened, why, because, and then they find out what is the reason, what system modification can be done to prevent these things can happen again. So that is called focus on system rather than individuals. Investment on managerial time, capital and technical expertise. So also this is the total quality management invest on managerial time, capital and technical expertise. So, increased investment in education and training to understand the complex process and foster partnership. So, there should be partnership and collaboration, and also investment in education and training. So, education and training and empowering the staff so that the standard will be maintained at the same level. A steadfast long-term vision. They should have a steadfast long-term vision. So, where is the organization now and where are they going? What is their moving towards? Is it high reliable organization? So maintaining high standards, high quality, continuity care, safe patient care. So what is the vision of the organization? A steadfast long-term vision. It should not be short-term, like it should be a long-term vision. So by the next 5 years, where we wanted to stand. Then cautious use of minimal standards. Always strive for achieving excellence. So not only just using minimal standards, they always go for excellence care. That is the that's very important. Excellence, always strive for excellence. Rather than doing the minimum required, they will go for higher standards always. And continuous ongoing quality improvement, it never stops, it goes on continuously. Continuous ongoing improvement. Then total quality management philosophy, the other importance are problem translate into opportunities to improve quality. So whatever there is a problem, for example, there is a high fall in one of the units. So what they will do, they will translate it into an opportunity for improvement. So high fall rate is an opportunity for improvement. What we can do for it? Let's benchmark ourselves to other organizations to find out where we are standing and then move forward. That's called a sorry, problems translate into opportunities to quality improvement. Open and ongoing communication. So there should be open communication always. There should be collaboration. Organizational culture that daily talks and acts like quality. So every day they talk about quality. Every day they act quality. Correct? Identification, understanding and focus on customer needs and expectations. So how we can identify the customer needs? By doing some customer satisfaction survey, finding out like focus group, like calling a group of patients and finding out what they wanted to be improved in terms of access of care or availability of care or the standards of care, and then improve from there. So identification, understanding and focus on customer needs and expectation, and ongoing pursuit of customer satisfaction. Customer satisfaction is very important. So it's a patient-centered care. Then team emphasis on perfecting system and processes in the delivery of patient care. Always emphasize on the processes and systems rather than rather than looking into one individual performance, look into the whole system performance, how it is, what we can do in the system to automate it, to prevent this error from happening, how we can barcode this, how we can prevent the patient identification error by looking by the healthcare provider to the identification band or barcoding, so that the exact name will be linked to the medication. So how we can fix the system to prevent the medical administration events like that. Constant learning and improving. That's another importance of quality management philosophy. Then let's move on to another topic, that is Edwards points on managing quality. So for Edward has 14 points in managing quality. So what are the 14 points of Edwards in managing quality? One is create consistency of purpose towards improvement of products and services. So there should be a consistency of purpose. What is our purpose? There should be consistency of purpose towards the improvement of products and services. Adopt a new philosophy of doing things right the first time through effective training. So provide effective training and do it right in the first time. So the rework can be prevented, and rework is always costly. Then eliminate the need for inspection. Prevent the defect, deficiency or error. So eliminate the need for inspection. No need to inspection. So do it correct from the first time itself. So no need for the inspection. In the practice of awarding business on price tag alone. So let's say that if the price, based on the price, the reward is provided. No, you should stop that practice of rewarding business on price tag alone. Improve constantly and forever every process for planning, production and services. All the aspect of this thing, planning, production and services needs to be improved. Train the employees to know what the job is, why it is being done and how to improve it. So train the staff to know what is the job, why is to be done in this way, why you shouldn't be skipping, you should you should follow the say all the processes and how to improve it. Adopt and institute leadership. The aim of leadership should be to help people to do a better job. Drive out the fear so that everyone may work effectively. So if there is fear, of course they will not talk, right? So drive out the fear so that everyone may work effectively. So break down barriers between staff areas, emphasize teamwork and not competition. So there should not be any barriers between staff areas and there shouldn't be any competition in staff areas. Eliminate slogans, exhortations and targets for the workforce. These never help anybody to do a good job. Concentrate on improving the system to make it easier for the staff to do a better job. So eliminate slogans or exhortations or targets for the workforce. So like let's say this unit done it perfectly and why this unit cannot be. So these competitions and slogans and exhortations should be stopped. Eliminate numerical goals. Emphasize quality and methods, not quantity. So numerical goals should be eliminated. So it shouldn't be the quantity, how many, rather than how well it was done. What is the quality? Then remove barriers that rob people of pride of workmanship. Eliminate the annual rating or merit system. Institute a vigorous program of education and self-improvement for everyone. Quality begins and ends with education. See, quality begins and ends with education. Put everyone to work to accomplish transformation. So it should be from top level to the bottom level. Quality improvement means all employees trying every day to do their job better and not to maintain a minimum level of competence to satisfy the manager. It is not minimum standard, it should be the complete standard. Let's talk about another topic, that is services and products. So services are performance rather than objects. They are intangible, cannot be measured, tested or verified in advance to assure quality. So services are performance, right? Services are heterogeneous, having high labor content, high common cost variability from provider to provider. So when you provide services, different providers do in a different way. So there will be a common cost variations, customer to customer and day to day they do differently, right? So there should be a lot of common cause variability. Production of services is inseparable from its consumption. So it is consumed by the customer as soon as it is rendered. Services are perishable. They cannot be saved and resold or provided at a later stage. Let's talk about a different topic, structure, process and outcome. So this concept is originated by Avedis Donabedian and these represents a complex sets of events and factors. So these are causally related. So this is originated by Donabedian and it is a complex sets of events and factors and is causally related. What is the meaning of causally related? That means the structure leads to processes and the process leads to outcome. That is called, it is causally related. So the structure means the resources available for care delivery. This include facility or organizations, equipment, budget allocation, qualified or skilled staff and professionals and technology. So it means all infrastructure required for a care delivery process. What is process? Process is the procedures and methods for care delivery and producing outcome. How the patient is diagnosed and treated in the healthcare setting. So this is called processes. How the result is obtained, how the outcome is obtained, the steps in obtaining the outcome, that is called processes. So it can include the clinical processes, care delivery process, and also administrative and management processes. So what is clinical processes? It's like assessment, planning, laboratory test, interpretation of results, administering medications, and managing complications. So these are the clinical processes. And what are the care delivery processes like registration, patient transfer, etc. And there is some administrative and management processes like leadership and interactions. Outcome. The procedures and methods of care delivery and producing outcome. How the patient is diagnosed and treated in the healthcare system. What is the outcome? So the clinical outcome like complication rate, mortality, morbidity rate, false rate, etc. Functional outcomes like activities of daily living status, and perceived or experienced outcome like patient and family satisfaction, employee satisfaction, etc. So in clinical outcome, we can consider the falls rate, the pressure injury rate. So let's say if there is a high falls in that particular unit. So what are the structure? What is the education and competency of the staff? What are the environmental redesign that you can provide? So those all comes under the structure. Then what are the guidelines? What is the steps that you implement to prevent the falls, like clutter-free environment, non-skid shoes, or assistive devices, or whatever you provide, the education to the patient and family. So these are the interventions or the processes. And what is your outcome? Outcome is the reduced false rate or zero false rate. So that is the outcome. So that is the clinical outcome. Functional outcome is the activities of daily living, and also perceived or experienced outcome is patient and family satisfaction, and also the employee satisfaction. So there are some common weaknesses in monitoring and evaluation. So what are the common weaknesses? Joint Commission listed some common weaknesses in traditional monitoring and evaluation practices. So frequent focus on clinical aspects of care only rather than full series of interrelated governance, managerial support, and clinical processes affecting patient outcome is a weakness. So only concentrating on the clinical aspects is a issue. So that is a weakness. So you should be concentrating not only on the clinical aspect, you should be concentrating holistically on everything, the governance, managerial support, everything you need to be concentrating on. Then compartmentalization. Compartmentalization of quality management activities based on organizational structure like department or discipline, like medical care department, surgical care department, or oncology department, or discipline. So rather than the flow of the patient care. So the patient may go from medical care to the surgical care to the long-term care. So rather than compartmentalization, this should be done collaboratively. It should have around the flow of the patient care. Then focus on performance of individuals rather than how well the processes are performed. Coordinated and integrated, and how the process can be improved. So focusing on performance of individuals is a weakness. So what we have to do, why rather than who did this mistake, you have to concentrate on how this happened. So how this happened, what was the system gap, what is the process gap that lead to this one, what are the system issues, and you need to fix that one. So focusing on performance of one individual is a weakness. Frequent initiation of actions only when a problem identified rather than trying to improve the process. So when a problem happened and you working on it, that's a reactive way of action. But proactive means you are trying to find out what can go wrong in this process, and then you are fixing it before the issue happens, like near misses or anything, that failure mode effect analysis. So you are looking into all the processes, what can go wrong in all these processes, and fixing that issue. That is called proactive approach. So reactive approach is the weakness in quality management, in monitoring and evaluation. Then separating the dimensions of quality of care. Example, appropriateness from effectiveness, rather than integrating all efforts to improve quality of patient care outcome. So separating dimensions of quality, for example, appropriateness from effectiveness. So you only concentrate on appropriateness. You are not concentrating on effectiveness. And you concentrating on efficacy, not concentrating on the patient centered. So all these are the weaknesses in monitoring and evaluation. Let's talk about some waste in healthcare. This is another topic, lean. So using the acronym downtime is a great way to remember what are the waste. So downtime, D is defects, O overproduction, W is waiting, N non-utilized talent, transportation, inventory, motion, and extra processing. Let's do how it is related to healthcare. So the defects are the products or services that have flaws or don't meet the specified quality standard in some way. So a defect results in either product rejection or rework. So rework is costly. When you need to redo the things, it is costly, which requires resource to correct it. Example, wrong labeling of specimen that leads to rejection of samples and it requires to redraw the sample. So that is the defect. Overproduction. Overproduction is when you produce more goods or outputs than you need. So in healthcare, like for example, documenting some information on multiple records in patient files. For example, if there is an incident happens, you record in the nursing forms and also you record in the nursing notes, or the medication administration, you record in the electronic medical record, EMR, and then you still record it in the nursing notes. So recording it in multiple files is a overproduction. Then waiting. Waiting refers to any idle time or delay in the process where work isn't actively being done, like standing in line, equipment breakdown, material shortage, or inefficient scheduling. So they have to wait a lot of time. Example, long ER waiting time, long OR waiting time for a procedure, waiting for discharge. So these are the based in healthcare. The non-utilized talent. Non-utilized talent is the insufficient use of employee skill, creativity, or potential contributions within an organization. So fostering a culture that encourages employee involvement, empowerment, and collaboration is key to addressing non-utilized talent or waste. Example, lack of staff input in problem solving. For example, the staff know how to fix the dialysis machine, he know how to troubleshoot, but instead of utilizing the staff talent, you are calling the outside vendor to come and fix the machine. So this is a non-utilized talent and it is time consuming and also it is costly. Then transportation. Transportation refers to unnecessary movement of materials, items, or information within the production processes. Example, the items required to perform one procedure is stored at different locations so that the staff needs to move from one place to another place to collect all the items needed for one procedure. Or moving the patient from one room to another room. So once the room is empty, cleaning that room and moving that patient to that room and then cleaning the other room. So it is a waste in healthcare. So inventory is the accumulation of excess materials, products, information, so work in progress beyond what is immediately necessary or otherwise idle. For example, build-up of extra supplies and that get expired, and then you have to do daily inventory to see how many is available, how many is in need, how many is to order. So inventory is the accumulation of excess materials and products. So that is a waste in healthcare. So another one is motion. Motion refers to people, information, or equipment and their unnecessary movement due to workspace layout, searching for misplaced items. Example of this waste include excessive walking, reaching, or handling of materials that could be streamlined or eliminated. Excessive walking to complete a process. Then extra processing. Extra processing is also called over processing. It refers to any activity that is not necessary to produce a functioning product or service. Example, too many inspections or testing that goes beyond what is necessary. Too many inspections. Let's talk about a different topic, that is rules for healthcare reform or redesign. So the care is based on continuous healing relationship. Patients should receive care whenever they need it, either in face-to-face visit, virtual, telephone, etc. Healthcare should be responsive at all time, 24 hours a day and every day. So that is, the care should be continuous. It should be based on continuous healing relationship, and the patient should receive the care whenever he needed. It doesn't matter if it's day or night or whatever. Then customization based on patient needs and values. So some patients, they have different values based on the religions and their values. So the customization should be there. The patient as the source of control. So patient centric. He is the focus, and then he decide what he needs. The patient as the source of control. He has the right to refuse, and he has to right to choose. Then shared knowledge and free flow of information. So the patient should have access to their own medical information and clinical knowledge. So all the information related to the patient should be shared with him. Evidence-based decision making. So care should be based on best available scientific knowledge. Safety as a system property. So should reduce the risk and ensure safety and prevent and mitigate errors by proactive means. So safety as the acronym. So these are the rules of healthcare reform. Need for transparency, informed decision making. So you should tell the patient these are the options available, and we should inform them in their own health decision making. Then anticipation of needs, anticipating patient needs rather than simply reacting to events. So what is his needs at the next level? So you should anticipate it, anticipation of needs. And continuous decrease in waste, should not waste the resources or even patient time. Like waste, like we already talk about what are the waste in healthcare, like overproduction, like doing unnecessary lab results to the patient waiting for discharge, patient waiting for OR. So all these waste needs to be reduced. Then cooperation among clinicians. There should be collaboration and communication to ensure appropriate exchange of information and coordination. For example, the intensive care physician should be coordinating with the gastroenterologist um, or medical or whoever. So the orthopedics and all those, there should be cooperation among clinicians. And so this is another topic, quality management principles of ISO 9000. So there is few principles. Principle 1 is customer focused organization. Principle 2 is leadership. Leaders establish unity of purpose and direction of the organization. So they should have a vision from the leadership itself. They lead by example, and then the others will follow. Then involvement of people. People at all levels are essence of the organization, and full involvement enables their ability to be used for the organization. It shouldn't be the top level management. It shouldn't be the lower level management. All levels of the people are the essence of organization. So they are needed in one or the other way. So involvement of all the people is another principle. So what are the principles? Customer focused organization, the leadership should have a vision, and the involvement of people. Let's go to another principle, that is process approach. Desired result is achieved when resources and activities are managed as a process. We already talked about what are the processes. And principle 5 is system approach to management. So identifying, understanding and managing system of interrelated processes contribute to effectiveness and efficiency in achieving organizations effectiveness. So it should have a system approach, not like one directorate or the other directorate, not working in silos. It should be as the whole system approach. Then continuous improvement. So always improve. So if one portion is improved, then look for another opportunity for improvement. So continuous improvement. Then factual approach to decision making. So it should be based on data and information, not based on assumptions. Assumptions may be wrong, but if data is there and then the data says your fall rate is high, your hospital acquired pressure injury rate is high, if the data is saying so, it is. So work on it. Then principle 8 is mutually beneficial supplier relationship. So an organization and its suppliers are interdependent, and mutually beneficial relationship enhances the ability to create value. So there should be a supplier supplier mutually beneficial supplier relationship, correct? Then let's talk about cause and effect diagram. Cause and effect diagrams are used to identify all possible causes of an effect, a problem or an objective. So they are sometimes called Ishikawa diagram. So for example, the 4 M's like methods, manpower, material and machinery, or the 4 P's like policies, procedures, people and plan uh, are commonly used uh, starting points. More than 4 factors may be identified for complex topic. The factors are placed in boxes at the end of each of the rib of the backbone. I will show you an example. So the causes of identifying by brainstorming a group of members. Example, long waiting time in ER, delay in scheduling OR booking. So if there is an issue, so we find out some problem and then we brainstorm and we identify the by a group of people, like let's say 10 people from different areas, and then we brainstorm them. So we identify what is the real causes of this problem. So let's go to an example here. So here there is challenges in identifying patient accurately. So what are the challenges in identifying the patient accurately? So there are a lot of challenges. So the brainstorming of 10 group of people, it reveals there is problem with technology, a problem with workload, problem with staff factor, problem with miscellaneous patient factor and knowledge gap. So whatever is the challenges, we write it down and then we categorize under subheadings like CLMA was down, CLMA was not working, slow net down, CLMA is closed to loop medication administration. This is a technology. Then slow net connections, short staff, all procedures are at the same time and the physicians are in a rush to finish their work and then taking shortcuts from the staff side. Human behavior, there is a language barrier, then frequent call bells and then assumptions that I already know the patient, so why I should identify this patient again. And then the physicians are in a hurry also. Then confused or non-cooperative patients, no ID band, and patient refused to wear the ID band, and then lack of awareness on importance, and then misconnection between theory and practice and educational awareness. So all these points are gathered by doing a brainstorming session, and then this should be put it into different subheadings, and then we know that. So these are the main issue that the reason for challenges in identifying patient accurately. Then let's talk about quality improvement projects. A quality improvement project is a systematic data-driven approach to improve processes. For example, fault risk assessment, patient outcomes, ER waiting time, or system performance within a specific setting. By using evidence-based methods to identify gaps and testing small piloting areas and making incremental change. So what is a quality improvement project? So this is a systematic method using a data-driven approach to improve processes. For example, false rate or pressure injury rate. So whatever processes you found, you are doing a systematic data-driven approach to fix that issue. So this is an evidence-based method to identify gaps. So you look into the gaps and then you apply in a small area, piloting it into a small area and making small gradual changes. QA projects aims to enhance efficiency, safety and care quality. Let's talk about Duran's model of quality improvement. The three quality management processes. So it's also called Duran's triology. So there is three quality management processes also called Duran's triology. They are quality planning, quality control and quality improvement. So let's see what is quality planning, quality control and quality improvement. Quality planning is identifying and tracking the customers, measuring and prioritizing customer needs and expectations. So we are planning here. Identifying the process and issues critical to effective outcomes. So what is the critical critical factor? So like maybe making a Pareto chart and find out what is the main thing that you need to address it. And setting quality improvement goals and designing a function or service responsive to customer needs and developing the processes capable of producing desired outcomes. So these are called quality planning. And then let's go to quality control or quality measurement. So measuring the extent to which organization achieve and maintain the desired outcome. Measuring the current performance and its variance from the expected standard. So based on the expected standard, what is the variation, and measuring key processes and outcomes, describing variability in process and reducing or eliminating unnecessary or inappropriate variation, and providing feedback, comparing actual performance to intended. So what is the actual performance needs to be current performance, what is the current practice, and what is the right thing to do, what is the intended, supposedly what is the standard, so what is the variation, and utilizing the data to manage the process. So measuring what is the current practice and what is the expected one, what is the standard, and then what is the difference. So this is called quality control or quality measurement. So measuring the quality, the extent. Then what is quality improvement? So quality improvement is using a collaborative efforts and teams to study and improve specific existing processes at all levels. So analyzing the causes of failure, dysfunction or inefficiency, and systematically implementing optimal solutions to a chronic problem. Routinely analyzing and disseminating best practice through education, and using scientific problem solving methods to improve processes, performance, and achieving goals. So that is called quality improvement. So remember all these three terms. What is quality planning, what is quality measurement, and what is quality improvement. So all these collaborative efforts, how you are day to day, you are improving your quality, analyzing the cause of failure or dysfunction, and then how you are improving on it. This is called quality improvement. Let's talk about another topic about leadership styles. So there are different types of leadership styles you may see in your day-to-day life. So the autocratic leadership, participative, empowering. So let's see what one by one. So autocratic leader is a leader who is very directive and controlling. Employees have little or no power on decision making. Leaders makes the decision and announces to the group. So the leaders take the decision and ask the other team members to follow. That is called autocratic. So do you know the example of an autocratic leader? So in code blue, you need an autocratic leadership style, right? You take the decision and you ask the team member to follow. Okay, give them 1 milligram epinephrine IV now, and you start CPR. And so those things. So in code blue, in emergency situation, the very important leadership style is very useful leadership style is autocratic leadership. But in the real workplace, the autocratic leader is not the good style of leadership. Then participative leadership. Employees have some degree of autonomy in decision making in processes, but leaders seek input from the employees. So if there is an issue, the leaders come to the employee, and then they work as a facilitator. They seek the opinion, and then the leader draft an idea or problem and get a suggestion and make a decision. Empowering leaderships are leaders share power with employees, provide support and resources. So the employees are empowered to be as leaders. Then diplomatic or consultative leadership. The leader presents the decision and invites questions. So this is the decision. Do you have any answer? Involve employees in action plan, responses to concerns, encourages employee support. So the solution is already made, and then you present it to the staff, and then you will ask them, do you have any questions? So here the employees are involved only in the action plan. Then democratic leadership. A leader detailed the problem, defined the limits, and asked the group for a decision. Democratic leadership, the leader tells about the problem and what are the limits and where is the upper and the lower limit, and then we ask the group for a decision. And transactional leader. This is based on rewards and punishments, focusing on performance and compliance. So those who have good performance, they will get reward. Those are not compliant, they will get a punishment. Transformational leadership. Leaders inspire others and employees to change the expectation and motivate the employees to work towards the goal. So that is the transformational leadership. Then lazy is fairy leadership. Leaders provide minimum direction and allow the team members to make the decision, which can encourage creativity but may lead to lack of guidance. So the leaders they don't care about how it is done. So there is a little decision from the leadership, and then the employees are encouraged with their own creativity to take their own decision. This works well if the employees are self-motivated, goal-oriented, and innovative. Otherwise, this is a very bad style of leadership. Let's go to another topic is variation in and run chart rule interpretation. So we were talking about variation. So as I said earlier, the deviation from set standard is called variation. For example, let's talk about false again. So for false, there is a standard, like when a patient comes and when you identify the patient as moderate fall risk, these standards to be done. When a patient is low fall risk, these standards is mandatory. When a patient is high fall risk, these standards are mandatory. So then we measure, is this all the standards were implemented, yes or no? So what is the deviation from the set standards? So it can be clinical or in the processes. So either positive or negative. So positive is higher compliance in hand hygiene, right? So in hand hygiene, we expect 100% compliance. Negative is reduced fall rate, reduced infection control rate. So we need zero falls, right? Zero infection. So it can be either positive or negative. So that is variation. So run chart interpretation. A run chart is the practical and easy way to understand variation embedded in the data you are measuring. So at the Institute of Healthcare, IHI, reached an agreement on 4 run chart rules that have found to be most relevant to healthcare applications. So I will tell you run chart. Run chart means we put all the data in a run chart style. So there should be minimum of 10 to 12 data points. So we put it as a run chart, just a run chart. And then there is some rules, like there should be a median in the line, and then by looking into the run chart, you look for 4 items like a shift, a trend, too many or too few runs, and astronomical data points. I will come to an example, then you will understand more. So a shift means a run chart is 6 or more consecutive points, either all above or below the median. So if there is six or more data points above the median, that is called a shift. Values that fall on the median do not add or break the shift. Skip values that fall on the median and continue counting. You watch these slides multiple times, then you will understand. There is an example, and how to read the run chart is in the next topic. So this is about the theoretical part, and then you understand this theoretical part, and then you go to the explanation at later stage, and you will understand. Then a trend is, a trend is a run chart is 5 or more consecutive points all going up or all going down. That is called the trend. So here you ignore one of the point when counting. Like if there is 2 same points, if the value of 2 or more successive points is the same, ignore the one of the point when counting. Like values do not make or break a trend. So here the points that touches the median will not count in a shift. In trend, the same number of values we will not count. So run is one or more consecutive data point on the same side of the median is called a run. And astronomical data point is unusually large or small numbers. So let's go to a graph, and then I will explain this to you. So here the number of measures, see how many number of measures it has. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So there is a lot of, I think there is a lot of 30 plus data in this run chart. So a run means, see, above the median. So this is one run. This is the second run. Whatever is a group of data that comes before the. So go to this. Yeah. Then this is another run. This is another run. So fourth run, fifth run. This is the sixth run. This is the seventh run, and here it is the eighth one, 9, 10, and there is 11 runs. This is 11 runs. Correct? Then if you look into it, see 1, 2, 3, 4, 5, 6 data points above the median. 6 data points above the median is a shift. So if 5 data points going like down or up is called a trend. See 1, 2, 3, 4, 5 data points going down. So that is a trend, and it can be an astronomical data point because it's an unusual going up, correct? Okay, so that's about the run chart rule interpretation. There is some few questions coming at the later stage. You can, when you go to the review questions, there is some of the questions there. Then customer. What is the concept of a customer? Customer is the one who receives goods or services. Customer provide perceptive quality. So perceptive quality is provided by a customer. So what he perceives is the one that he provides to us. So there is external customer and also internal customer. When a healthcare system is considered, there is internal customer, like who are the internal customers, like the people who, like physician, pharmacist, support staff, receptionist, administrative staff. They are the internal customers within the hospital. But the external customers are the patient, the family, the vendors, the purchasers, insurance companies and government agencies, educational institutions, regulatory bodies. These are the external customers. So what is the customer expectation? Both internal and external customer look into whether the expected needs are met. So optimizing in prevention, access to all, high quality and cost control, listening to and communicating, evidence-based practice, respecting patients, responding in a timely manner, patient privacy. So these are the customer expectations, right? So the patient expectations. So these are the patient expectations or customer expectations. So how we measure the customer expectation? By identifying by surveys. Which service meet expectation, which are not, which one you feel like to improve. Are you receiving extra that you do not require, etc. Like, is there any extra lab works are done that you don't want? So all these things can be done by surveys. Then by interviews, and so by interviewing the patient you will find out, in interviewing the customer you will find out the customer needs. Focus groups, by a group of people, by giving open-ended questions to capture qualitative data, that is called focus groups. And also by brainstorming, that's also a group of people and there will be a facilitator who will brainstorm with one issue. So just for one issue, what is the ideas that they are expecting. That is how you identify the customer needs. So customer needs are identified by surveys, interviews, focus groups and brainstorming. Let's talk about time management. The process of planning and controlling time spent on activities to maximize productivity, efficiency and work-life balance is called time management. So how you can do time management? By list clear goals, plan for the day and schedule breaks, set priorities based on urgency and importance. Start with priority items and leave less priority items for a later time. So make a to-do list in the morning, a big list of items, and then prioritize which one I need to complete it today, which one I can complete tomorrow. Who are the people? What is the deadline? Is it deadline today? Then I need to finish it by today. So, and then make a to-do list. And if you are in the leadership level, you can delegate some of the tasks to your subordinate. And learn to say no. Sometimes you have to learn to say no. Refuse non-essential tasks and minimize distractions, like a lot of phone calls. You need to keep it silent and you have to work on your activities. Break large tasks to smaller ones. Bigger ones, you have to make it a smaller one. And then do it now and do not leave it for the last moment. So if you can do it now and don't leave it for the last minutes. And the difficult task, you need to do it in the early time. That's called time management. So have you understood time management? This is applicable in our daily life also. Let's talk about never events. So acknowledgement to National Quality Forum. Never events was first introduced by Ken Kaiser, former CEO of National Quality Forum NQF, in 2001. These are serious preventable adverse events. The list is revised multiple times and now consists of 29 serious reportable events grouped into 7 categories. So these never events shouldn't happen. Never events means what? This should never happen in healthcare quality, right? In healthcare setting, these events should never be happen. Okay, so never events, surgical or invasive procedural events. So any wrong side surgery, wrong patient, wrong surgical or other invasive procedures were performed on a patient. Unintended retention of a foreign object. Intraoperative or immediately postoperative, post-procedure death. So in surgical or invasive procedural events, it's grouped into 7 items. So these items are under surgical or invasive procedures. Wrong site, wrong patient, wrong surgical, unintended retention of the foreign body, and intraoperative or postoperative death. These are never events. It should never happen in healthcare settings. So the second one is about the product or device events. Use of contaminated drugs, devices or biologics. Device is used for functions other than is intended. Some devices, they are used for a different function, but it has some catalog. So it can only used for these procedures, but some smart people, they use it for a different one. So devices is used for functions other than as intended. That is a never event in healthcare settings. Also, intravascular air embolism that occurs while being cared for in a healthcare setting. So air embolism is a never event. Then patient protection events like discharge or release of a patient or residents of any age who is unable to take decision or other than an authorized person, an unauthorized person. So like discharging patient to a unauthorized person, like, so that is a never event. So you shouldn't be discharging a patient to an unauthorized person. Then patient death or serious injury associated with patient elopement, that is disappearance. Patient absconded and then the death happens. Patient suicide or attempted suicide or self-harm while in the healthcare setting. It should never happen. Then for the care management events, a medication error, error involving the wrong drug, wrong dose, wrong patient, wrong time or wrong rate, wrong preparation or wrong route of administration. So medication error is a care management error. So it should never happen. Unsafe administration of blood and blood products. Maternal death or serious injury associated with labor or delivery in a low risk pregnancy. Low risk pregnancy with the maternal death is a never event. Death or serious injury of a neonate associated with labor or delivery in a low risk pregnancy. In low risk pregnancy, the baby also shouldn't be dying. And then the fall is a never event. Any stage 3, stage 4 and unstageable pressure ulcers acquired after admission is never event. So stage 1, stage 2 is accepted, but stage 3, stage 4 unstageable deep tissue injuries all are never events. Patient death or serious injury resulting from failure to follow up or communicate lab pathology or radiology results. So you didn't communicate with the patient on the lab results or some pathological results and the patient eventually dies. This is a never event. You delay in communication of the lab results and the patient did not take the treatment and he dies. So that is a care management event and it is a never event. Then environmental events, so like electric shock. A line designated for oxygen or other gas to be delivered to a patient contains no gas, the wrong gas, or is contaminated by toxic substance. So electric shock, because some of the hospitals have nitric oxide, oxygen and medical gas, right? So if that is given in a wrong, that is it is a never event. Then burns, like for example during the surgery there is a diathermic burn because of the carelessness, because the way how they handle the tip of the needle. So there is a diathermy burn. So this is a never event in healthcare setting. Physical restraints or betrayal. So physical restraints or betrayals are, so we are restraining a patient. Actually in healthcare setting, we shouldn't be restraining, but in some organization we put side rails just to prevent the patient from falling. But like, it like restricting his movement is a never event. Like putting mitten is okay, but if it is tied to a side rail of the bed, the patient cannot move his hands, that's a restraint. And radiological events like death or serious injury of a patient or staff associated with introduction of metallic object into MRI area. Sometimes in the MRI area, if the patient is having some metallic object implant, the machine will pull up because of the high what is that, the magnetic power. So that's a never event. So there is one more item. Seventh category is the potential criminal events like abduction of a patient or resident of any age, sexual abuse or assault, and physical assault. So these are the potential, these are the never events in healthcare settings. So a majority of the organizations look into all these never events and try not these events to happen in healthcare settings. Then let's have some review questions, cause and effect diagram review questions. In evaluating long waiting times in OR booking, a healthcare quality professional best demonstrates components related to staffing, methods, measures, materials, and equipments utilizing run chart, RCA, pie diagram, Ishikawa diagram. So the correct answer is Ishikawa diagram. That is called cause and effect diagram. So run chart is a chart that we plot the diagram on a run chart, and then we put a median, and then we look for shift trends or astronomical data points that we already talked about this in the slide. RCA is the root cause analysis, right? RCA is root cause analysis. So if there is an issue happens, if there is a serious injury happens, like a medication administration error happens, then we are finding out what is the root cause. Is this a system issue? Is this a process issue? Is this a human error? So we are looking into those aspects. That is called root cause analysis. What is pie diagram is a part of a whole is called pie. Then which of the following is essential component in a performance improvement report? When you're writing a performance improvement report, what is very important? Approval from leadership? No, you don't need a leadership approval to write a performance improvement report, right? Data analysis and display. Of course, you need a data analysis and display in the performance improvement report. Individual performance review, we don't put individual performance review. Team composition and attendance also no need. So when you are writing a performance quality improvement report, so you have to write, this is the data, this is the analysis, and this is what we are going to work on it. This is the major issue. This is what we are going to work on. So that data analysis and display is the important component of the performance improvement report. The quality improvement teams are beneficial due to why we need a quality improvement. When there is a quality improvement projects, why you need a quality improvement team? For managing the team, for promote competition, for maximize expertise and perspectives, and authorize solutions to problems. So the correct answer is maximize expertise and perspective. So because of it is a group of people, the expertise can be maximized. So false rate per 1,000 patient days addresses which of the following aspects of care? The fall rate, monitoring, process, outcome, and structure. So the correct answer is it's an outcome measure. False rate is an outcome measure. So what can be the process measure? The interventions that put forth to prevent, or the percentage of staff who had attended the fall prevention education. That is a process measure. But the false rate itself is a outcome measure. The compliance to fault risk assessment addresses which of the following aspects? So the fault risk assessment that is an intervention, right? Risk assessment was performed or no. So what type of measure is this one? Monitoring, process, outcome, or structure. So the correct answer is process, because you are measuring the process of the fault prevention. Healthcare quality professionals can best communicate organizational values and commitment through. So here, healthcare quality professionals can best communicate, establishing a multidisciplinary task force, disseminating monthly newsletters, creating a mission statement, leading by example. So the correct answer is leading by example. So when you lead by example, the other people will follow the organizational values and commitment. A facility decided to implement independent double checking, but compliance has been poor. In addition to assessing the cause of poor compliance, the most effective way for organization to improve compliance is, so here independent double checking was implemented, but the compliance is not good. So you are assessing the cause of poor compliance. Why there is not good compliance? And in addition, what you can do? Install Omnicell to stock the medication? Of course, no. Initiate written demonstration as part of staff competency. So maybe you have done the education, but maybe not all of them know that one. So you start the written demonstration. Redo staff education. You already educate the staff, so you don't need to re-educate the staff, but you ask them how you perform. Initiate a written demonstration. Review and revise high alert medication administration policy. So the policy is not an issue here in this one, independent double checking. It's a process. So why the compliance is not poor? It is related to the staff. Staff are not compliant. So there is nothing to do with the process, this policies and procedures. That is a structure. So this is a structure. This is a process. So initiate written demonstration as part of staff competency is the correct answer. Then then the appropriateness of care is primarily focused on utilization management, a key dimension of quality of care. Equivalent to case management, the degree to which healthcare services are coherent and unbroken. So what is the correct answer? The correct answer is it is a key dimension of quality of care. So what is this degree to which healthcare services are coherent and unbroken? This is continuity of care, correct? Okay. A medication is ordered for a diabetic patient. Its capacity to improve health status as a dimension of quality or performance is, so like metformin in controlling diabetes is efficacy. The correct answer is efficacy. Then the dimension of quality or performance that is depend upon evaluation by the recipient or the uh, patient or observer of the care is respect and caring. So this is the patient centric, right? Safety is not, continuity or availability is not the one. So that depend upon the evaluation by the recipient. For example, the customer, patient, how he identify. So that is respect and caring. That is the aspect that he can measure as the recipient of care. In If in the continuous quality improvement processes, we increase our emphasis on customer satisfaction and outcome of care, which two dimensions of quality or performance must be incorporated into all quality management activities. So here the quality, we increase our emphasis on customer satisfaction. So customer satisfaction and outcome of care. Which of the dimensions? So customer satisfaction and outcome of care. It is availability is not outcome of care or customer satisfaction, but respect and caring is customer satisfaction. Competency is also not outcome of care. Of course, it is respect and caring and effectiveness. Effectiveness is the outcome of care. So the correct answer is effectiveness and respect or caring. Then the key dimension of which of the following key health care issue is more problematic for ambulatory care than inpatient areas. So in ambulatory care settings, what is the main problem in this one? Ambulatory care. Reimbursement of care, of course, no. Access to specialty care, appropriateness for treatment settings, and quality of care provided. So out of these options, the correct answer is access to specialty care. So for the problem of ambulatory care, the issue is more problematic in ambulatory care is access to specialty care compared to inpatient. See, in inpatient settings, there is specialty care, but in ambulatory care, there is no specialty care. So that is how you need to look into these questions. Then the quality professional can best facilitate the development of a quality culture in the organization by, we just talk about it, leading by example, right? Encouraging leaders to commit to a culture of excellence, leading by example. Assessing the organization's readiness to commit to change, preparing a long range plan, leading the cultural transformation redesign. So none of this. How a person can best facilitate a quality culture is by leaders. The leaders should commit to a culture of excellence and they lead by example. The task of setting up an ambulatory care setting, quality management or quality improvement program that focus on outcome as a measure of treatment effectiveness is difficult because, so in ambulatory care settings, the outcome is difficult because the patient remain in control of treatment. Patient care outcomes are determined by the payer. There are no required medical records. Expected outcome for ambulatory conditions are too obvious. So here in ambulatory care settings, majority of the patients, they remain in control of their treatment. So that is why outcome as a measure of treatment effectiveness is difficult in ambulatory care settings. In developing program to evaluate the effectiveness of physician care, a primary care clinic would select which one of the following indicator. So we are evaluating the effectiveness of a physician care and this is a primary health clinic. The patients will express overall satisfaction. The contract lab will provide results within 24 hours. So if the patient express their satisfaction, that is the patient satisfaction. So here this is a lab is a different department. The staff complies with all infection control policies. Newly diagnosed hypertensive patients are controlled within 6 months. So this is an ambulatory care settings, remember, and all the newly diagnosed hypertensive patients are controlled within 6 months. So this is evaluating the effectiveness of a physician care. So the physician is performing very well in controlling the hypertension for patients within 6 months. So that is the physician effectiveness, correct? Okay. Then the quality management cycles based on Juran's quality triology, that is quality planning, quality control, and quality improvement. So that exclude the lab's activities to monitor equipment, requires a departmentalized approach to quality management, encompasses only the non-clinical aspects of quality management, and incorporates information from strategic planning. So in quality management cycles, which one is the correct answer? Because the strategic planning has its quality planning, quality control, and quality improvement, right? So the departmentalized approach is a weakness in quality, right? Non-clinical aspects of quality management, no, we have to concentrate on, that's also a weakness in quality, correct? So the correct answer is incorporate information from strategic planning. So strategic planning is the hospital's overall planning, quality control, and quality improvement. The perception of quality by a patient receiving care in an ambulatory care center is influenced most by the physical environment, the caring staff and physician, new technology, the physician's technical competence. So here the patient receiving care in ambulatory care settings. So the main issue here is the patient satisfaction. That will be affected by not by the physical environment, of course, not by the technology or physician's technical competence. It's by the caring staff and physician. The quality management philosophy assumes that, what is the quality management philosophy assumes? Most problems with service delivery results from system difficulties. Frequent inspection is necessary to improve quality. So in total quality management philosophy, it doesn't say that they should have frequent inspection. Most problems with service delivery result from difficulties with individuals. So we are not concentrating on individuals in total quality management. Top management leadership in quality activities disenfranchise employees. That's also incorrect. So the correct answer is the problems with the service delivery results from system difficulties. So always they say the total quality management says the service delivery is result from system difficulties. Then one fundamental difference between monitoring product quality and service quality is based upon the fact that the service is easier to measure and verify in advance. That is not correct. The service is always perishable. Yeah, this is incorrect. A service is more heterogeneous than a product. There are more service delays than product delays. So this is an accurate statement. So the correct answer is the service is heterogeneous than a product. Then Juran's triology of clinical initial analysis of data analysis and information is called. So when we review the analysis and the data, when we measure the data, this is not quality planning or quality improvement or quality project. The answer is quality control or measurement. So when it comes to data, it is a control or measurement. The relationship of structure, process, and outcome is casual because the structure leads to process and process leads to outcome. We already talked about this in the theoretical aspect. The dimension of quality that is depend upon the evaluation by the recipient or the customer or the patient is respect or caring. Incorporating total quality management key concepts, compartmentalization is a weakness. Compartmentalization or departmentalization is a weakness in implementing quality improvement. Which of the following is the best definition of process? Process is the series of steps to achieve a desired outcome. So that is called process. It is not the steps required for care delivery, implementation of guideline and policies that is a process, but that is not the best definition. Technical aspects of care delivery also a process, but the best definition is process leads to outcome. Series of steps to achieve a desired outcome is called process. A potential conflict between the philosophy of total quality management and quality improvement in healthcare is the challenge in Deming's principle is to cease dependence on inspection. Okay. The most effective leadership style in crisis situation, like in cardiopulmonary arrest, is autocratic leadership style, as I explained. The leadership or management style that is used in total quality management is participatory leadership. All the team of the people are involved. Participatory leadership in total quality management is participatory leadership. The leadership style linked with management by objectives, MBO, is participatory. So management by objectives. So it is not autocratic, not transformational or empowering. It is the participatory leadership. MBO, management by objectives. So we have some objectives or visions in mind and then we manage. So that is participatory. Hospital A is merging with Hospital B and there is a redesign in quality improvement process. What type of leadership style is required here? So here the leadership style required is diplomatic or consultative leadership. What type of leadership style is required when employee participation is critical for the successful implementation of the action plan? So there is an action plan. For the successful implementation of the action plan and the leadership participation is required, this time you need a democratic leadership. The leadership style that is said to motivate employees and optimize the introduction of change is participatory leadership. Run chart rule interpretation review question. So look into it. So this is a run chart. So how many numbers here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and then 16, 17, 18, 19, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35 data points are there. So here there is a new process implemented. Let's say waiting hours in waiting hours. So ER, let's say ER waiting hours, it was so high and then a new process was implemented here and then the ER waiting time reduced. Let's look for the question. So here this is an astronomical data point, right? Statistical signal of a non-random pattern. So here this is an astronomical data point. So here the number of data is 29 and the minimum run should be 10 and maximum run should be 20. So here this one is the 5.46. 5.46, the point that meet the median we will not count. So when you look into this one, this is one run. All these are one run. We should ignore this data. So this is one run and this is also 5.46. We will not count. So this is another run. So there is only two runs. So the data points is 29 and there should be minimum runs of 10 and maximum runs of 20. So what is the issue here? Too few runs. This is the issue in this chart. So here the number of data is 29 and minimum is 10 and maximum is 20. So here also this one is here the median, this is median. So this one is one run, this is 2, this is 3, this is 4, this is 5, 6, 7, 8 runs. Sorry. So 8 runs. So this is also very few runs. So, so in this data point, there is an astronomical data point. So this is a very high number. It's an astronomical data point. Here, when you look into the runs, this is 1, 2, 3, and we will not consider this one. 4, 5, 6, 7, 8, 9, 10, 11, 12, and 13. So this is enough points of runs, right? Yeah, so there is enough number of runs, but there is one astronomical data point. Is this as a trend? See, this one is in median, so we will not, we can count this one, right? So from this one, 1, 2, 3, 4, 5. So there is 5 data points coming down. That is a trend. This is a trend, right? So 1, 2, 3, 4, 5. 5 data points coming down is a trend. So this one has an astronomical data point and also there is a trend. So in trend, we will not count the same numbers. Same numbers we will count only once. But in shift, when there is a number fall on median, we will not count. That is the shift rule. Okay, incorporating total quality management key concepts. Compartmentalization is a weakness in improving quality improvement. We already talked about this question. Then a medication is ordered for a diabetic patient. Its capacity to improve health status as dimension of quality is efficacy. Patients are happy with the service. When you are evaluating how many patients are happy with the service provided, you are measuring which dimensions of quality: appropriateness, respect or caring, effectiveness and efficacy. So the correct answer is respect or caring. So this aspect is very important. There will be multiple questions in the exam. Under quality improvement paradigm, which statement is incorrect? Incorrect. The focus is on competency of individual practitioners. So we don't look into individual practitioners, right? The focus on efficacy and effectiveness of processes. The focus is on a patient. The focus is on organizational performance. So we look into organizational performance, yes, as a system wide. The center is the patient. The focus is on efficacy and effectiveness of processes, but not on the individual practitioner. So this is the incorrect statement. Common causes of problems in processes refers to one-time situation, temporary situations, acute situations, and chronic situations. So the common causes are chronic situations. It's common It is a common issue. So it is a chronic situation. One-time situation is an astronomical data point. Temporary situation is also either can be a shift or a trend. Acute situation also a temporary situations, but chronic situations are common causes. Which one of the following describes the successful outcome of a quality improvement process? Customer satisfaction, improved statistical data, quality improvement initiatives, staff empowerment. So which one is the successful outcome of a quality improvement process? The correct answer is customer satisfaction. Yeah. Keep in mind, these type of questions will be asked in the exam. The centerpiece of outcome management in healthcare is morbidity and mortality, quality of life of patient, improved statistical data, and staff empowerment. So the centerpiece of outcome management in healthcare is the quality of life of the patient, the customer. So we always care about the patient as the center. So the correct answer is quality of life of the patient. Thank you, and we'll see you in the next topic. If you didn't understand this one, repeatedly see this lesson, and then you will understand. Write your comments what you wanted to include in the next session, and subscribe to the channel. Then I will know. Okay, thank you, and see you in the next topic.